I don't know who has it. Okay, so this is the now you will get just best of 5 questions, not the EMQs. Okay. So this is the first one. See here, the first question that is about the self-harm. A 15-year-old self-harm patient that was readmitted to the hospital, readmitted like he or she was previously also having the same complaint, that was calmed by the nurse, next step by the doctor. Okay. Now see, in this stem, they have not given us the clue. What is the point? What is the point, like where they have seen why the patient was readmitted, she's calmed or not? So I cannot comment exactly upon this scenario, but yes, for that, please do read the guidelines of the self-harm. You have a clinical case of this self-harm too. Whenever any patient coming to you with, especially with a non-accidental injury suspicion, the child is coming to you with a self-harm, will what will you do? Contact for urgent assessment or contact for urgent admission. So what is point here? Any case coming to you self-harm, even that is readmitted, you have to go for the readmission. Urgent admission is the point that should be done. So not a very good stem, whatever whoever has written this one. For that, I will tell you we have to read the guidelines. These are the from your pediatric guidelines, the topic of the self-harm. Okay. In the self-harm, the what is the point in the management? They will confuse you like the patient was admitted, then she went, and then it again, this is admitted. It means that they just trying to drag you towards the point, like a patient is coming again and again with the self harm, will you admit or not? We will definitely admit that patient coming every time with the self harm, this patient should be admitted. Okay, and this is very much clearly written in one of your clinical case where the one 15-year or 12-year-old girl has taken some paracetamol and she's just trying not to be admitted. So see the management. If available in your trust, contact CMH's crisis team for advice. Otherwise, admit the patient overnight. Admission is the first point that should be done in any case of poisoning, drug overdose, or any self-harm cases. Okay, so here the answer that should be urgent admission. Okay, a girl with a recurrent epistaxis that is diagnosed with a bleeding disorder. So see here not again the same, what like she's having recurrent epistaxis, bleeding disorder, and can this be a case of hemophilia? That is this a case of hemophilia? Definitely not. That is usually they are not going to present with recurrent epistaxis. It may be that is an X-linked recessive. Why will be coming, right? Okay, is that factor deficiency? Now, what is the difference? Can the factor deficiencies come to you with the this recurrent episodes of epistaxis? No, very less likely. Why? The patient, please do remember when we are going to talk about the bleeding disorder, we have to see is that superficial bleed or is that a deep bleed? Okay. In the superficial bleed, the bleed may be in the skin. Okay. Right. So superficial bleed may be mucosal bleed like this epistaxis, like GI bleeding, any mucosal bleed that is a superficial bleed. It's not a deep bleed, right? Okay. In the skin bleed, if that is present, it's a superficial bleed. It may be due to your blanchable or non-blanchable, right? If that is non-blanchable, what is the problem? If that is blanchable, what is the problem? So let us talk about the bleeding disorder that may be superficial, that may be bleed. If that is superficial, then we have to see is that blanchable or not blanchable. If it is blanchable, then what is the problem? That can be your maculopapular rash. It is not a bleed, okay? If that is non-blanchable, then this is a bleed and it's most likely due to, maybe due to platelet defect, like your ITP, okay? And if it is non-blanchable, but that is palpable, it means that is a vasculitic problem. Okay. Deep bleeds, when they are present, it's always and always due to clotting factor deficiencies, right? So, bleeding that is superficial are the deep. Superficial bleed may be due to platelet problems, or that may be due to vasculitic problems. In the vasculitic problems, there will be non-blanchable but palpable. But in the platelet disorders, that will be non-blanchable but they are not palpable. Okay. So see here, this patient is having recurrent epistaxis and that is having factor deficiency. No, not at all. They usually present with the deep bleeds. That may be bleed in the joint, that bleed in the your psoas muscles and any other deep bleeds. So we are left with the von Willebrand. What happens in the von Willebrand? There is factor VIII deficiency. Yeah, that is present. But why I'm saying like this factor deficiency, they are going to present with the deep bleeds. This von Willebrand, it has platelet defect like deficiencies, and it has factor VIII deficiency. Why? Because this is your von Willebrand factor that is going to adhere here your platelets and here your factor number 8. Okay. So due to this presence, defective function of your platelets and defective function of your factor 8, there may be superficial bleeds, there may be deep bleeds. So recurrent epistaxis in a girl, whatever is the problem, we should think always and always of von Willebrands. Okay. The right answer here is von Willebrand. Okay, next point, this we have discussed multiple times. 5-year girl, she has episodes of the blackout. She has several attacks. Her mom has same episodes. Her uncle died at teenager and EEG, calcium level and blood glucose, they are all normal. So what is your diagnosis? What is your diagnosis here? That is your long QT syndrome. Okay. Suggestive of the non-accidental injury. Yeah. Suggestive of the non-accidental injury, that is a tibial metaphyseal fracture 1 year, spiral fracture 14 years, oblique fracture 5 years. So please see here, when you talk about the fracture non-accidental injuries, you must know what are the fractures which are very highly suspicious of this non-accidental. These metaphyseal fractures, one of the highest suspicions, having highest suspicion of the non-accidental injury. And the next point we have to see, what is the age of the patient? Can we have this non-accidental injuries usually in 14 years? Very less likely. In 5 years, the toddler is playing, moving here and there. He may have fracture, but 1 year child with the metaphyseal fracture, that is a very, very highly suggestive of the non-accidental injuries. Here is the list I have taken here. That is the fractures which are very much pathognomic of the non-accidental trauma. That is your metaphyseal fracture. It is one of the high. See here, here they have given the fractures with high specificity for the non-accidental. On the top of that, that is the metaphyseal fractures. But always, always look at the age of your patient. The child is mobile, the child is immobile. Okay. Now, the next list, that may be your scapular fracture, spinous, this one, all. But please, in the your pediatric patients, to remember your posterior, usually they will give the standards of these posterior rib fractures, your metaphyseal fractures. Okay, these two are most common. They will label as your non-accidental injury fractures. You have to see what is the age of the patient, the child baby is mobile or not mobile. Okay, again, see, this is a repetition. The question number 1 and 5, they are the same. Okay, this is again the same. Okay, let's talk about the question number 8. A 6-week-old tachypnea, palpable femoral pulses, right? Systolic murmur, CRT that is 3 seconds, slightly increased, heart rate that is 160, liver is 3 centimeter below the right costal margin, SpO2 that is 90%. What should be done? Oxygen, IV fluid resuscitation. Okay, oxygen plus furosemide. All right, oxygen plus fluid boluses, IV prostaglandin. Let us talk why this is not a case of IV prostaglandin infusion. It's not a case of cyanotic congenital heart situation, that is 96%. So this is gone. Right. Okay. Next point, why shouldn't we go for oxygen and the fluid boluses? Oxygen, that is SpO2, that is 96%. So should I go for oxygen and IV fluid bolus? No, not at all. Oxygen and IV fluid resuscitation. Okay. Oxygen and IV fluid resuscitation, oxygen and furosemide. So what should be the answer? Okay, this is the answer here. If if we talk about, this is the exactly the answer. Like the age is 6 weeks. Okay, age is 6 weeks. Child is tachypnic. He's not having any is cyanotic congenital heart. He's not having coarctation of the aorta. Systolic heart murmur that is present, but 6 week old child usually that okay that should be like absent. Heart rate 160, that is not very much increased. Liver 3 centimeters, yeah, that is descended, but not very much. Okay. So see here, yeah, Dr. Dan, I'm telling the point why they have selected oxygen here. Number, please do remember while solving to choose the best of the five, I have to see it's not always that they are not saying you choose the perfect of the five. Okay. Like in this question, what is the perfect of the five? If I talk about the perfection, they have given me the oxygen. Maybe it's on oxygen, maybe it's not on the oxygen. That is 96%. That is quite normal for a 6 weeks old baby. Why should I go for oxygen? But in the other options, if I choose this IV prostaglandin, he has not given they have not given me any clue towards the cyanotic congenital heart. So that is why I will not choose it. Oxygen, why? There is tachypnea. There is a murmur that is present. CRT is also slightly increased. So oxygen is just to increase, like meet the metabolic demands of the child may be increased, and I am not left with any other options where oxygen is not given. So should I go for IV fluid resuscitation? Definitely not. Why? CRT slightly increased, but here liver is descended, seems to be descended along with the increase in the along with the systolic murmur. So I should go for oxygen and furosemide. Okay. Heart rate, that this baby is not very much technical, like I have to go for this resuscitation of the fluid. CRT, that is slightly increased, but it's due to fluid or something that is going impend towards the heart failure. Okay. So right option here is the oxygen and furosemide. Okay, I must say, like doing this paper, it will create many confusions. So we will just concentrate on the points they are clear and they're not getting us confused. Okay, so needle stick injury, again, this scenario is not complete. What should be the made? Okay. See the question number 10, needle stick injury by the nurse. Mother refused to test the baby. What should be done now? This is the interpretation who has written this recall, but it's really not the exact scenario. This is from your ethics, basically. What the child has come in the hospital most likely for any test or any investigation, any lab investigation, but there is a needle stick injury by the nurse to the child. Now the mother is saying, I will not go for any testing of my child, any lab investigation of my child. So what should be done now? According to the ethical laws, patient safety should be the first priority. Okay, not a complete given the complete scenario here. So we will not discuss this one. I have sent, I guess, a page about how to deal with the needle stick injuries. This question that is not basically from the needle stick, it's maybe basically from your ethics. So what you should do, that would be dependent upon what exactly the scenario is. Okay, read the needle stick injury and the measurements, like how to calm and how to what is the best for the interest of the patient. Now see here again, here patient is the diabetes mellitus. He is having persistent early hyperglycemia. We should think of dawn phenomena. We should think of this somogai phenomena. For that, we must know what is the night 2 p.m. sorry 2 a.m. BSR of the patient. if it is a case of the your Down's phenomena, then you will increase the long-acting insulin, and if it's that is a Somagai phenomena, then we are going to decrease. Again, this is an incomplete scenario, but please do remember, for that you have to read the Down phenomena and Somagai phenomena, right? Okay, next, nurse forgot to give the antibiotics. This is a repeated one. What will you do first? The first thing is the patient safety. Okay, then is the incident report. You will inform your consultant, you will inform the parents, you will do what is the best for the child. So here you will give the antibiotic to the patient. That again would depend what options they have given to you. Child had a history of the cough, coryza, that was just 2 days ago. Now please see here what change may be present. Then he saw blood in the urine and developed flank pain. Up till now, I'm just thinking of like the child is having upper respiratory tract infection. I may think that is 2 days before or that is 2 weeks before. Okay. Now the baby is coming to me with the hematuria, right? If before hematuria, that was just 2 days before, upper respiratory tract infection is present, what I will think of Dr. Aisha, I may say that is the case of, okay, Dr. Aisha, you please tell me what may be the problem here. Yeah, I will think this is a case of IgA nephropathy. If that was 2 weeks before, I may think of that is a case of post-streptococcal glomerulonephritis. Okay, now see the difference in the scenario. Urine analysis. Okay, urine analysis shows negative, oh sorry, plenty RBCs, but no caste, had no family history. So, what is the right answer here? I will just tell you. Okay, Dr. Noman, what is the answer here? Dr. Noman, what is right answer here? Okay, so Aisha is saying that is nephrocalcinosis. Okay, nephrocalcinosis, all right. Dr. Noman, what is your view? Yeah, the answer here is nephrocalcinosis. Yeah, Dr. Aisha, what is the key point for selecting? No, cost is not the issue. No cost mean there is not any infection, and cost is not going to give you any clue towards any diagnosis. The point here is that I have to see, is that painful hematuria or painless hematuria? So they have given me the full scenario of the IgA nephropathy, right? But yeah, yeah, Dr. Vakas. But see here, they told me the patient has painful hematuria. So painful hematuria among 1, 2, and 3. This is your nephrocalcinosis. Okay, that is why the right answer here is the B. All right. Okay. Next, disease need to notify public health. Okay. Now, for question number 14, please see. For that, you have to see what are the notifiable diseases in the UK. I have sent a pamphlet in your groups too. And okay, that encephalopathy, that is going to be notified. Measles, yes, that should also be mumps. Scarlet fever, that is not present here. So this means this is present, this is present, this is present. Okay, Dr. Mariam, what about your mumps and what about your acute encephalopathy? Now please see here. This is the point why we have selected measles here. Okay, the mumps, that was all. See here, scarlet fever, that is also present. All right, and this mumps, that is also present. Yeah, that is an urgent. So do memorize this form, make any mnemonic for this one, but yes, the need to memorize here is I must know what is urgent. Routine, I will not now see in this question. They have given me some diseases which are a part of the routine notification and some that are of urgent. So what I need to learn here, I need to learn what are urgent ones. Okay, they may give you any one urgent and other routine diseases. So that is why measles is the right answer here. Okay, next is the question. There is a hot, tender lymph node that was formed. That was erythematous skin. Temperature that was 13, a very high. What is the next step? Should I go for review? Should I go for commencement of the antibiotics, ultrasound, or CBC and CRP? Okay, so what is the right answer here, Dr. Sohail? What should I select if I talk about this tender lymphadenopathy that is present? Dr. Fatima? Antibiotic. Okay, why, Dr. Fatima? Why I should go for antibiotics here? Okay, see here, for that you will read the guidelines of the acute cervical lymphadenopathy, right? We also have to go for some investigations, but there are some indications. Okay, please to read acute cervical lymphadenopathy guidelines. They are very important. Sometimes they will ask you, they will give you just the size of the lymph node. It's less than 2 centimeter, or if it is more than 2 centimeters, then that is significant. Less than 2 centimeters systemically well, no treatment, just reviewing. This may be one question, all right. And when the child assist lymphadenopathy size is more than 2 centimeters, there is the child is seems to be not like that is not sick, not unwell. Okay, Dr. Sara has said that maybe a case of your CBC and CRPC here. They have given you some indication. Okay, local infection, ENT, skin and eye that was present, lymph node that was more than 2 centimeter. Okay, treat with the antibiotics and just review the patient. Okay, there are some indication if that is hot, that is red, that is tender, sore throat with immunocompromised. Okay, then you should go for CBC culture, CRP, and other serologies. Okay, now see this one point. Okay, just let me show you this acute lymphadenopathy. That is just one here. Cervical lymphadenopathy, that is your page number 63. Okay, now they have very specifically like mentioned here. Should you go for investigation? Okay, urgent investigation. If any of the following that is present, then you will go for investigation. What are that sign and symptoms? If they are present, then you will go for. Otherwise, a tender lymph node where the child is not systemically unwell, you will simply go for this antibiotic treatment and you will review this child. If you get any supraclavicular lymph node or suprasternal lymph node, if the size that is more than 2 centimeter, but at 4 and 6 weeks, it means the child was having acute lymphadenitis. I have given him antibiotics and I have reviewed this child, but still at 4 or 6 weeks, the size of the lymph node that is not decreased, I will go for investigation. The size that initially was 2 centimeter, but now it's growing in size for more than 2 weeks. Okay, not return to the baseline that is less than 1 centimeter at 8 to 12 weeks, then I have to go for investigation. This one investigation that is upon your just on your lymph node. You have examined the lymph node. You are saying like the size is going to increase, it's not going to on its baseline. Then I will, and clinically, what are the signs? Any sign of the sickness, compromise, petechia, dysphagia, hepatosplenomegaly, persistent fever for more than 4 to 2 weeks, then I will go for investigation. Okay, please do read the cervical lymphadenopathy guidelines. They are very important. Any question, what is the size, where is the lymph node there? Sometimes they may give you supraclavicular lymph nodes and sometimes they will give you cervical lymph nodes. There is change in the management in the selection of the answer for that. Okay, next question, that is your question number 16. Okay, that is scrambled egg rash. Asked about intranasal influenza vaccine. So this is simply a question. Right. Should we go for influenza vaccine? Who is having this? Is your flu vaccine? I suppose that is having some component that is just like your egg protein. Okay. The child was having egg allergy, egg rash that was present. Should I go for this influenza vaccine? Latest guidelines says yes, you can go for influenza vaccine even if the child is having allergy to the eggs. So now they are asking you, Should we give for under hospital supervision? Should we refer the patient for the allergy assessment? Then we should go for this influenza vaccination. And the child is can have at community level, like any center, any GP surgery level, that these vaccination can be given. What is this? A is the right answer here. See here. This is British Society who says any setting, including your GP surgery and schools, the patient who are having egg allergy can safely be vaccinated with a nasal influenza vaccine. Okay, so this A is the right option. The patient is having allergy. He or she may have flu influenza vaccine at any community level. Okay, now see here 17. Sudden pain on the knee joint. He lies hip flexed, externally rotated. What investigation should be done? So please see here what should be the investigation. That is aspiration. That is okay. So what is the point here? What is your diagnosis here? Yeah, according to your guidelines, most likely if that is a case of your septic arthritis, that is most likely in the knee joints. Okay, so he, pathology in the knee, there is a change in the posture, the position of ease at the hip joint may also be present. So urgent, that is an emergency. The first thing that is your aspiration for that is to read your osteomyelitis or septic arthritis guidelines. Do remember that is an emergency. Any child coming to you with suspicion of septic arthritis, emergency operation theater should be alert. Okay, and this aspiration of the joint, that is the first step that should be done along with start of the IV antibiotic. Okay, 12 weeks child immunization. Please do remember I have sent up just one page for the immunization schedule of the UK. Okay, again see the repetition of the same question. Okay, this is also the repetition of the question: epilepsy well controlled on the carbamazepine and erythromycin. This question has been repeated 2 or 3 times. Drug inducer or drug inhibitors. Okay, I'm not going to discuss it again here. You should remember which one are inducers and which one are inhibitors. Okay, now pregnant mother, he develops chickenpox in the last 5 days of the pregnancy. She is fully vaccinated. So, what should be done for that neonatal varicella vaccine? Initially, that was 5 days, but now you should see 7 days before delivery and 7 days after delivery. Okay, what is right answer here? Okay, Dr. Wajiha, what is the answer here? You should observe and give varicella. You should give IVIG, give IV cyclover if the rash develops. What is the answer here? Okay, Dr. Fatima. This is the third one. Give IV. Okay, give IV cyclover if the rash develops. Give IVIG. So you will not go for IVIG here, Dr. Mariam. You will not go for IVIG here. Okay, let us read what they have written here. Okay, the baby is born to a mother who develops chickenpox rash but not shingles within 7 days before birth or 7 days after birth. Okay, give varicella zoster. Okay, antenatal chickenpox give as soon as possible after delivery, must be within 72 hours. Postnatal chickenpox give as soon as possible and within 10 days after initial exposure. Consider giving in different sites. Okay, can be given this one, this one. Okay, not needed if the baby is not born after 7 days of the appearance of the maternal rash. Okay, if varicella zoster that is not available, give I. Okay, so again, please do tell me, should we go for IVIG or should we go for the option number 3. IVIG. Okay, I again will see here. Mhm. Both options are basically correct, but let me show. This is varicella. Okay, so what is the right? Basically, there is a slight difference in this scenario, in that scenario. Okay, yes, we will go for IVA cyclover. If the child develops chickenpox rash, we should go for acyclover. But see here, the first point, neonatal varicella. If that is present 7 days before or 7 days after the birth of the baby, the first step is you should give varicella zoster immunoglobulins. Okay. Now, see the difference in the no, this is not the right option, B. This is also the correct one. And if we talk about this one and this one, this is the right, more right. But I tell you, like if anyone choose between this one and this one, these both options, they are correct. Why? If the child develops a rash, we should go for acyclovir. But the first step should be if the mother is having chickenpox, we should go for varicella zoster immunoglobulins. Okay? B and C both are correct, but B is more correct as compared to the C. Okay, right. Next is a 4-year-old boy with 4-week history. This one, okay, this is the same question repeated. 4-week history, 4-year-old. Bilious vomiting, malnutrition, not any other clue. Like we should think of other suspicions why they are present or why they are not present. Baby with the head nodding and flexion. Okay, these are the slam seizures. What is the best treatment for that? That is your vigabatrin. Okay. Macrocephaly is seen in NF1 or rubella. Very easy. Dr. Mariam, what is the right answer? Is this A or B? Like someone was discussing this point. See here, macrocephaly is not in case of rubella. They are microcephalic, they are IUGR along with having other features of the torch infections. So NF1 is the right answer here. If mother suffers from the rubella, what will be found in the baby? Rash or sensory neural deafness? So tell me, which one is more common? Dr. Vakas, Dr. Arifa? Sensory neural deafness or rash? Please see here, that is very specific for that. Na? Sensory neural deafness rash may be present if mother is suffering from any torch infection, but if she's suffering from the toxoplasmosis, rash may be present, but sensory neural deafness will not be present. So here we have to choose this sensory neural deafness. Someone was discussing like they have chosen this deafness along with rubella. Always concentrate what they are trying to ask. See here, rash may also be present. Sensory neural deafness may also be present. But rash, if we talk about other torch infections, rash is usually present. Sensory neural deafness, that is very typical of with your rubella and with your cytomegalovirus infections. Okay. Next, again, not clear. Down syndrome developed, not clear. Diabetic child comes with very high blood sugar. Next, most again, this is the repetition of the question. Some they will talk about the urinary ketones, blood gases. So we have to go for diabetic ketoacidosis. Okay. So acidosis, why? Because that is an emergency. Ketones may or may not be present. Like if they are present, we are not going to treat the ketones. In any case of the high blood sugar, we are going to treat the acidosis. BMI definition, I told you yesterday in your test class. This is one of the favorite question, obesity in your RCPCH all theory exams. Anorexia nervosa, obesity. So please do remember what are the definitions for the morbid obese, overweight, obesity, and all others. Okay. This is also the repetition of the previous question. Okay. Next, again, not very much clear, like 31, not clear. 32, they just a school canoeing, history of the rash, hepatosplenomegaly, and conjunctivitis. Okay. Rash, hepatosplenomegaly, conjunctivitis, that may be present, but this canoeing, basically, this one, maybe the baby has gone for this one. Contamination of the water, of the soil, or any flooded area with this leptospirosis may cause, with this bacteria may cause leptospirosis. All other features like your rash, your hepatosplenomegaly may be present many bacterial and viral infections, rash, hepatosplenomegaly, brucellosis, and all others. This conjunctivitis and this canoeing, that is giving me a clue towards the leptospirosis. Okay. Again, this is the repetition of the previous polyuria, polydipsia, what we should go for blood gas, blood glucose, urine osmolarity. Okay. This is also the repetition of the previous question. Sleep disturbance, had eczema. What causes the disturbance in the sleep? That was due to eczema, severe rash, severe itching. High strung disease, the scenario that was given, but is to confirm the diagnosis, rectal biopsy. Okay, confirmation of the high sprung disease, that is always on the rectal biopsy. Okay, again, see here, not a clear scenario. They just have given me as the answer. That was short stature, that was constipation and weight gain. Diagnostic, I don't know what were the other options, but this is a case of endocrine problem. The baby is short and baby is obese. Okay, please do always remember, short and obese, that is your endocrine problem. Short and thin, rule out any chronic disease. Okay, I told my previous students, we usually talk, like if we talk in Urdu, chota and mota, rule out endocrine problems. Okay, short and thin, chota and patla, rule out your chronic disease problems. That may be celiac disease, any other chronic disease. Here they have not given other clues, but yes, constipation, that is towards hypothyroidism. Why autoimmune? That may be in the scenario. Maybe in the options with the hypothyroidism, they have given autoimmunity. Okay, so do not get confused. You just clear your concepts. A 3 days fever, that was cough, breathlessness, able to take feed. Please do remember, you will concentrate on the breathlessness. You will not concentrate the child is able to take feed. Okay. On history, on examination, basal crackles in the lower lobe. Now you are just going to concentrate on the pulmonary edema. Okay. No, not at all. 3 days fever, cough, difficulty in breathing, that is present. It's a case of pneumonia. Which pneumonia? Lower lobe, that is present. This may be a case of lower lobar pneumonia. Okay. Basal crackles, bilateral or unilateral. Most likely this is a unilateral. It's a case of lobar pneumonia and the child is able to take feed. It's not a case of pulmonary edema. Okay. So what is the treatment? It's your oral cipro, amoxil, oral clarithrol, or IV ceftriaxone. For that, please do not follow what you are doing in your own hospitals where you are working. You have to follow the guidelines. Do read the guidelines of the antibiotics. Okay, I read the topic for the pneumonia from your guidelines. This is your antibiotics. We have to see in the scenario, has they given me community acquired pneumonia or hospital acquired pneumonia. The treatment is different for the community acquired and for the aspiration and for the hospital acquired. What we do, we usually like, I must not say, like, maybe you just remember the antibiotics we are using, just concentrate. In the community acquired pneumonia, that is mild to moderate or severe. Okay, Now you have to categorize your patient in your scenario. Is that moderate or is that severe? So is your patient moderate or severe? He is able to talk. That is most likely a case of mild to moderate community acquired pneumonia. So what should be the treatment? That is amoxicillin for 5 days. Okay, right? So that is your oral amoxicillin. In some question, they may ask you allergy to amoxicillin, allergy to penicillin. What should be the drug of the choice? Right. Next, this is again the repetition, ear piercing, and a murmur, echo, or blood culture. So this is a case of the infective endocarditis. What is your investigation of choice? What is investigation of choice? Yeah, blood. It's not echo. That is your blood culture. Okay. Boys with the severe flare of the eczema, right? Fever that is high grade, erythematous skin rash. What is your next step? Admit for antibiotics, ask mother for the compliance, increase dose of the hydrocortisone. So, what is your answer here? Now, the child has developed secondary bacterial infection. So, I will admit the patient for the antibiotics. Why? Flare of eczema that is present but high grade fever and erythematous skin rash, most likely your streptococcal infections, they are very likely to be present in the patients who have any breach in the skin integrity. Okay. Next, need urgent referral, convergent squint in the 6-month-old child. They just have given here the one answer here. For that, please just read the ophthalmology case of your FOP. I must say, like if you have not done anything in your ophthalmology chapter from your SOP, from your illustrated, read each and every line of your this clinical case. It will clear your concepts. It will give you all the answers of your questions you may get in your exam. Okay. Yes. And for urgent referral, I also one paper, one page I have sent for where you have to urgently refer the patient for the surgeries. Like if inguinal hernia is present, when you are going to refer the patient, when umbilical or paraumbilical hernias they are present. Okay, right. Next question. 2-month-old with E. coli responded to the treatment investigation. Ultrasound in the 6 week, DMSA, and ultrasound prior to discharge. For that, please, this is from your UTI guidelines, and you have to decide this is typical, this is simple UTI, and this is atypical UTI. Okay, we have done these guidelines uploaded in your videos too. What is the age of the patient? Okay, yeah, this is typical. Yeah, that is typical. Now that baby has responded to the treatment, and E. coli it is present. So ultrasound within 6 weeks. That is the treatment. Okay. Next one, you will definitely get one question from this scenario. And your FOP clinical case about nocturnal aneurysms, they also have explained each and everything about the questions you may get about nocturnal aneurysms. Okay. 10-year child with the cystic fibrosis has sputum culture positive for the pseudomonas. Given ciprofloxacin nebulization, she says she hates the taste of the, also, that is also from the previous one. She hates the taste of the syrup. She's 10 year. She can have this oral tablets. Diabetic girl Muslim fasting case. Reconsider parents about the fasting. Now you have to see the whole scenario. That question they also have written in the test exam too. Who did it yesterday? So that again would depend what the real scenario is. Okay. Sometimes we have to diagnose for the hypoglycemia when the prolonged fasting is going to cause a hypoglycemia in the child. Non-immunized child with stridor, subcostal retraction, and high-grade fever looks unwell. Acute epiglottitis, but please do remember a bacterial tracheitis that may also be having all these symptoms here. Okay, and drooling of the saliva that usually gives you a clue towards acute epiglottitis. febrile stridor. So we have differential diagnosis of the febrile stridor. Number one, that is your epiglottitis. That may be acute bacterial tracheitis. It's also febrile. It's also having this one. But the point here is that it's non-immunized by acute epiglottitis that is usually caused by H. influenza. So that is why they have selected here the acute epiglottitis. Okay, this is also again the question 45. Also the repeated one, the child is hypoglycemic, but he is conscious, he or she is conscious, then the treatment is this oral glucose. If the child is unconscious then and the child is present in home or present at hospital, if at home, then you will give intramuscular glucagon. If in the hospital, you will go for glucose. Okay, molluscum contagiosum, sometimes reassurance, sometimes observed. But if the child that is teasing towards the child is getting disturbed, having some psychological problem, then you should go for treatment. Okay, for molluscum contagiosum, I think have told AKP clinical cases book the whole scenario they have discussed for the management when to manage about this molluscum contagiosum. Okay, AKP clinical cases. The case number I exactly do not remember, but I will send you. Please give a read to that clinical case too. Okay, not a complete scenario, not a complete scenario. This one, okay. 24-month walk 2 months ago, preterm. Okay, signs of the bulimia nervosa that was also present in the task examination, binge eating and vomiting, bulimia nervosa. All others may be present, but bulimia means that is eating more and self-induced purging that is present. Okay. 2 weeks history of lethargy, limb spleen that is 2 centimeter, HB low, WBC is 5, platelet is low. So what is your diagnosis here? The sick looking child, the problem in the bone marrow cells, splenomegaly that is present, that may be a case of acute lymphoblastic leukemia. Yeah. Okay, next, do not invite to the party. Now, see here, just this, by this point, they are saying they have taken this point here, that is was a case of ADHD. Okay, forceful vomiting of developed font, please do, it's not a complete scenario here. Dehydration that is present, you must know what is the usual age of presentation. Usually that is 3 weeks of the age. When the child is having forceful vomiting, dehydration, pyloric stenosis, and must remember, not a good paper here, this one, exclusively breastfed baby, virgin mother, 14 months baby developed pallor, that is now, see here, the child is 14 months. Lethargy, HB low, MCV is low. Which nutrient? Definitely iron after 6 months. Now, please do remember, see here, yeah, that is iron. Okay. The point here is that 14 months old child, MCV is low, HB is low. So that is your iron deficiency. Lymphedema of the hands, poor peripheral perfusion, pink baby. So lymphedema of the hand is giving us clue towards which syndrome? Okay. Dr. Adnan, what is the lymphedema of the hand is giving us towards which diagnosis is basically that? Yeah, that is your Turner syndrome. Yes, Dr. Aisha. That is lymphedema, Turner syndrome, poor peripheral perfusion. Maybe all other like problems which are present in your Turner syndrome, they may have given, but just why they have selected number one, coarctation. Please do remember the most common pathology in the heart that is present in your Turner syndrome, that is bicuspid aortic valve. Okay, maybe they have given this bicuspid aortic valve too, but just due to the presence of the poor peripheral perfusion, we have selected this coarctation of aorta, right? Okay, next, that was a scenario of the DMD. Next investigation, CK. Next investigation, your CPK level. Okay, not complete one. 12-year developed joint pain after football match. He was ground well comparing to other peers. Diagnosis, I told you multiple times, like with the previous one. Whenever they have given you some limping of the gait, okay, always and always diagnose the cases with the age of the patient. In your RCPCH scenarios exam, the right answer I have seen that is according to the age. Okay. For that, if you have read, Dr. Mariam, have you read the table for limping gait, how to approach, and what are the investigations? Yeah. Okay. Dr. Sundas, have you read that table? Yes. Please do memorize that table. Whatever is the scenario, we will make our diagnosis of the limping gait. What is the age of the child? Bleeding after circumcision, the patient is in the shock. CRT, that is 4 seconds. What to give? Should we go for vitamin K? That is bleeding from our saline. Yes. Okay. Dr. Mariam, what is the answer right here? Yeah. Any child coming to you with the shock CRT4, we should go for saline, right? Vitamin D level 30 nanomoles. What is treatment? Treatment dose, prophylactic dose, or should we go for vitamin D and calcium? What is the answer here? Vitamin K? No, no, Dr. Sundas, not vitamin K. The child, any person coming to you with the shock, you should go for the first step, that is the saline. Okay, Dr. Mariam is saying we should go for vitamin D and calcium. For that, please, this is your answer. This is from your pediatric guidelines, right? Follow this chart. If the level that is less than 20 nanomoles per liter, if the level that is between 25 and 50, level is between 50 and 75, more than 75. So they have taken a change of 25 nanomoles per liter, right? So what you will do if it is less than 25, treatment dose that is given. Okay, what is my patient's level? That is 25 to 50. That is prevention dose of the vitamin D and lifestyle advice. Okay, it's between 50 and 75. Okay, that is just lifestyle, then nothing is required. Okay, now see what is the level is 30 nanomoles. Is that treatment dose, prophylactic dose, or vitamin D and calcium? What I should choose here is that treatment dose or prophylactic dose. Option B. Yeah, I should go for preventive dose. Okay, please do remember this table, very, very important. And this vitamin D guidelines, some guidelines you should learn. Just I must tell you, clinical cases, each and every line with understanding. It will cover, I think, almost all of your chapters, your systems. Okay, some guidelines read every line. This constipation, obesity, vitamin D, vitamin K supplementation. These are one of those guidelines. Along with like whatever guideline that is suggestive from your recalls, read every line, but these are very important. And from your vitamin D in your theory exam, you will get this table must. Okay. So see here 25 to 50. If it that is insufficient, prevention dose of the vitamin D and lifestyle advice. Okay. Treatment dose is different and prevention is basically prophylactic dose that is different. Okay. Here, basically, they do not. I should go for vitamin D. I should go for the calcium. See here, I should go for vitamin D. I should go for calcium. Definitely, when the level is any level. If the level is less than 25, I should go for vitamin D and I should go for calcium. If the level is between 25 and 50, I should go for vitamin D and I should go for calcium. But what they want to ask you, is should we go for treatment dose or should we go for prevention dose? Okay, next, mother and the baby in the foster care in pyloromyotomy, who will give the consent? Not given the option here, but please do from your AKP master course, who will give the consent? They have written very beautiful lines. Foster parents can give the consent or not? Mother and baby in the foster care. No, this is not a complete one. I must not say, are they talking about the mother was foster mother? They have adopted the child or not? So, no, not at all. And Roxana, I will not say like biological mother, this is not a complete one. Do not go on this one. That is your AKP master course. I have just sent that book to you, and you will read the topic of the ethics. This is, see here, who will give the consent? Parental responsibility. Please give a read to this line. This is from your AKP master course, the book I have sent, and in your ethics videos, I also have discussed the same, this one, parental responsibility, who can give the consent, okay? This one and this table, this box, that is must, okay? This one, see here, foster parents do not give, okay? Adoptive parents, they can give. See this one, please. If you foster parents do not have a right to give the consent for any treatment of the child. This one. Okay. Okay. So please do give a reading to this concept, the consent one and parental responsibility. Right? Okay, so this was all about this today's class and this paper, not a good one. Just clear your concepts. Do give a reading of the clinical cases, all clinical cases, and your guidelines, relevant guidelines. Okay, any question? Okay, yes, for the last minute, please give a reading to all clinical, each and every line. Just go by systems, each and every line of the clinical cases, uh, and relevant recalls, relevant your guidelines, okay, and just the boxes of the illustrated, not the whole chapters. Do not get confused. Revise your recalls this time, okay? All right. Thank you so much.